Good evening, everybody, and welcome to today's episode of Nutrition in Surgical Patients under the series of Let's Learn Surgery. We are very happy to have Dr. Biju Poattakat, who has been active in all the programs of learning general surgery. He will be delivering the talk, and moderating the session will be Lekha Sridharan. Radhakrishna, please do the honors of introducing Dr. Biju.
Biju is a great friend of mine to start with, and he is one person who calls a spade a spade. There are very few of his species, and he doesn't care a damn about anything. He believes in very special scientific methods of interpreting things and following them. But more than that, he is the head of the Department of Surgical Gastroenterology, JIPMER Pondicherry, and he is MBBS from Calicut Medical College. MS from Calicut too, I think, I'm not very sure, but he did MCH Surgical Gastroenterology with Sanjay Gandhi, Lucknow. Then he subsequently had training in almost every continent in HBB surgery and liver transplantation. And then he has a very special interest in academics, and he has done a variety of programs, primarily nutrition, HBB surgery, stoma therapy. He's done for nutritionists, he's done for stoma therapies, nurses, technicians, and simulation and surgery. You name it, he's done it. I think he's into every aspect of surgery, including minimal access surgery and robotic surgery. So, and organ transplantation. There's nothing he is not involved in. And I wish him, now that the COVID is almost over, hopefully, and everything is opened up, and there'll be a meeting a week in Pondicherry from now on. Biju.
Pondicherry has declared itself COVID-free, by the way. Moderating the session will be, as I mentioned, Lekha Sridharan. Ilango, please do the honors of introducing her.
Hey, you're muted, Ilango, please. Unmute.
Just a minute. So I had the honor of knowing Mrs. Lekha Sridharan. It's a small world. I recognize that some of her relatives work along with our nephrology unit. She is a pediatric dietitian working at Apollo Children's Hospital right now, and she serves as the head of the department and a deputy general manager at the clinical dietetics department at the Apollo Hospital, Children's Hospital. She is an ESPEN certified in nutritional assessment, and surprisingly, she is the honorary national secretary of the IAPN India chapter in Chennai. And she has been keynote speaker in multiple conferences at the Infancy Conference in Atlanta. She has had multiple presentations and poster presentations across, and is a co-author for Nutrition and Diet in Children Simplified, and a very accomplished PhD scholar. We welcome her. She's very popular with the surgeons too, so we can see that she has that golden touch to add to the clinical knowledge and support of our patients. We welcome her to the LLS lecture. Thank you.
Over to you, Biju. Would you want to share your screen?
Yeah, okay.
Thank you, Dr. Ilango. And it's what, like, the dietitians are always connected with the surgeon, especially the topic you see, the nutrition, when it comes to that interaction and that, the coordination is something which is really helpful to work it better. I hope all of you agree, both of you being the transplant surgeons, our part of the knowledge, what we have in sharing helps it. So I'm sure with this talk of Dr. Biju, it will highlight more about what are the additional dietitians' role as such we have. So towards the end, I'll just give my suggestion also, like how do we go in our unit too. So I'll just add on towards the end. And one more thing about Dr. Biju, I would like to add on over here. He's also the vice president of our IAP in India Association, in which we have both doctors and dietitians. And he's been a strong support, to helping us enlighten our knowledge too. So that support from the doctors, consultant, it's something which, is really works forward better when you have a teamwork. So I go ahead in inviting Dr. Biju, sir, please do the honor of addressing the topic. So it will be an enlightening section for all of us.
Yeah, good evening to all the organizers of Learning General Surgery. It was a tremendous journey over the last few years, and the quantum of educational support given by this platform is so enormous, and we should upload it. And I sincerely thank all of them for giving me this platform to talk about nutrition. Am I audible?
Yeah, yes.
Yeah, so one of the biblical word we have to remember in nutrition is malnutrition is a disease by itself. Okay? It's not an adjunct. It's a disease by itself. So that means there are some diagnostic criteria, there are some investigational tools, there are some management tools as well. So that itself is a disease. Okay. Let me introduce what is the burden of malnutrition in our hospital setting. Okay. This is one of the surveys we have done with a sponsored clinical trial with the Fresenius Kabi across Asia. Okay, so you can see many countries participated in this, including India. This study is basically about to assess the malnutrition burden. What is the incidence? Till this study was done, we didn't know exactly how the hospital patients behave in a global way. So what it revealed was we have a significant problem of unintended weight loss, and it is more in India compared to other countries. This is one of the very key findings of this survey. So we have identified that we have some problems to tackle here. Now, the extent of malnutrition. Malnutrition is a spectrum, but even if we have several scales, we have to measure. As I mentioned, it's a disease by itself. So generally, we assess malnutrition as a mild, moderate, and severe malnutrition. But there is a low, moderate, and high risk as well. If you see in India, compared to other countries, it is from moderate to high range, whereas other countries, it is from mild, low to moderate range. So India has a peculiar problem at hand to tackle. So malnutrition is not always about deficiency. Okay. So sometimes the patient may look highly nourished, big man, weight, all these things may be there. But when you see the actual physiological process of nutrition, excess weight is actually a form of malnutrition. So both deficiency and excess are dangerous in a surgical patient, specifically in the nutritional point of view. Nutrition is not just food and eating habits. It is actually multifactorial. So unless the general socioeconomic status of the society improves, you will not get all patients in a better shape in a hospital bed or operation table. Okay. So the ultimate solution is the socioeconomic improvement. So in countries where socioeconomic status is poor or very poor, that person will get attacked with the disease, and the existing malnutrition will get worse. And this is the usual story we encounter in most of the third world countries. And nutritional point of view, whatever we boast about our country, India continues to be a third world country. But that is not the most important cause of malnutrition. The most important cause of malnutrition in our setting is hospital itself. So that means by virtue of being in the hospital, it inflict the disease of malnutrition to anyone who is otherwise also fit. A patient is coming with a good nutritional status, a hospital environment can make him into moderate or severe malnutrition group. So the moment he's in hospital bed, unless we start thinking about what nutrition we are planning, he's on the verge of risk of malnutrition. That is because there are no nutrition support team. We always gets carried away with the hanging IV fluids and all that. Pseudo satisfaction comes. For a particular patient, the moment he gets sick, many patients starts to avoid certain food according to the regional preferences, that when the food is required in more quantity, they start eating less. So what essentially happens, see, there are a lot of stored materials in the body. For any crisis, all this gets eaten up during hospital stay, and finally, you will not have calorie and patient will end up in calorie protein deficit. More over and above this, we are giving more fluids with no control, which will dilute all the components, and serum concentrations of all the transporting proteins will come down. And we think that we'll be giving 1 gram meropenem to the patient, but at the cellular level, you will not get a 1 gram. So what essentially happens when you don't feed the gut? Feeding the gut is feeding the body as well as feeding the gut itself. So gut itself is a separate system. So if you don't give food to the gut, there will be negative nitrogen balance, and the gut itself will undergo certain transformation. So its mucosal thickness will decrease, cell will start less proliferating, villus height will decrease. There are a lot of functional changes will happen. Ultimately, what happens is the nutrient absorption will decrease, patient will have diarrhea, and it will end up in significant malnutrition. So the nutrition by oral route is a must for the gut integrity. Nowadays, the last 5 years, enormous amount of literature has come, and most of them conclude that gut is the second brain of the body. So this is a very critical understanding. We talk about encephalopathy, we talk about delirium, we talk about sodium balance. So unless gut integrity is not maintained, the patient is not going to recover. The 3 cardinal principles of nutrition, what we have to remember is catabolism is the rule at rest. So even if you don't do anything, catabolism is going to happen. So the anabolic environment is to be created. That's why we eat. So if you don't positively and consciously create anabolic environment, catabolism is going to take its toll. Whatever trials we do about PN, EN or combination, the significant point is nutrition is a must and root has only secondary importance. We cannot tell a patient that, see, you have too much infections and we cannot give TPN if the patient is not taking oral. This is the second point I wanted to emphasize. Third point is a nutritionally unfit patient needs to be made nutritionally fit. There is no point in operating a nutritionally unfit patient. Why? Because why we operate for malignancy and other diseases? Because we are targeting something called a rehabilitation. Complete recovery to what he was before the surgery. So the overall diagnosis to complete rehabilitation will get delayed if you operate the patient early, if the patient is unfit for surgery. So these are the 3 cardinal principles we have to remember in nutrition. So till now I was talking about the burden and the incidence and the demography. Now, how to medically diagnose malnutrition, how to assess the severity. As I told, malnutrition is, please do not consider malnutrition as a condition. We have to consider it as a disease by itself. So if you don't have the mental state to analyze with too many formulas, you don't have people to do it, and your conditions are not mature to do it, you don't have a nutritional culture in your hospital, please consider that the patient is malnourished unless you positively prove otherwise. This is the dictum word we have to keep. So several methods are there: anthropometry, biochemical, clinical, diet history. But whatever it is, there is no single marker to diagnose malnutrition. Finally, at the end of the day, it is a multifactorial assessment by the clinician or dietitian or the concerned or motivated nurse. So it's a final clinical assessment we make regarding malnutrition. So even you take albumin, albumin is the most important thing we keep on discussing in rounds and bedside. But you know that many of the societies have removed albumin as a nutritional parameter. So we have to very soon, in 2 to 3 years, we have to forget albumin. It is no more a nutritional marker. Superficially speaking, there are risk screening tools. We do initial screening. Initial screening is basically based upon the weight loss and dietary intake and the sickness. So this will give a very clear idea whether the patient is at nutritional risk. Once we assess that the patient is at nutritional risk, then we go to the final screening tool. There are several guidelines by several societies, including European Society, which we follow regularly. There are auto calculators available. You can Google it and see. So all these very clearly tell you the patient is at severe malnutrition or severe risk, mild risk or moderate risk. For example, in this score, you have a score up to 7 and above, it indicates severe malnutrition. And almost always we depend on nutrition and doctors to assess the malnutrition. But sometimes we have a very patient-friendly tools to assess malnutrition also. Basically, these are highly useful in hospital environment, especially in Western setup. Educated patients, you can just mail them or WhatsApp this form. They will be able to fill many of the columns. If you are interested in nutritional survey, these sort of patient-friendly forms can be applied. This will also give some assessment. But now we went far ahead than this clinical assessment. We have a technology to help us. We have assessment tools to assess fat-free body mass. As I mentioned before, obesity is actually a form of malnutrition. We need to know how much lean body mass is there. So fat-free body mass index and fat-free mass is a very efficient tool to assess the risk of post-operative complications. So this can be measured. You can buy these products in online platform as well, although the specificity might be less compared to medically qualified devices. On bedside, let us say we have a moribund patient or a patient unable to move, especially orthopedic patients and all that. You have something called the quadricep thickness. This can be measured on ultrasound as well. Normally it is around 3.5. So what really happens is you press the quadriceps muscle up to the point of very minimal pain, and you can actually measure the diameter with a bony landmass. So these are all, these will give you the approximate measurement of malnutrition. Indirectly, it denotes the protein content of the human body. If you take CT, for example, CT is generally not done to assess the malnutrition. But what happens, most of our patients, or at least some of our patients, may undergo CT. Please make it a habit that you look at the CT, especially in the paravertebral region, especially the psoas muscle. You compare with a completely normal patient or a patient admitted with a trauma, you can see significant difference. You can even diagnose a sarcopenia based upon CT and other parameters. So the investigations already available with you gives you great insights to the assessment of nutritional risk. And if we are investigative mode, we can always do muscle biopsy and see how the nutrition affects the muscles. As I told, catabolism is a rule. Anabolism has to be created. So we might be wondering, you might have done a very good surgery, especially orthopedics and other surgeries. And after 2-3 months, the healing is very good, but the patient is not walking. There will be significant atrophy and the quality of muscle will be severely compromised. So very quick assessment formulas are there. You can just check weight loss, BMI, SGA, serum oil which is going to be taken off from the tool very soon. So if you don't have the mindset to go to complex formulas, please use very simple tools. And if you're not ready to do anything, you are not at all interested in the assessment of nutrition, just ask 3 questions. Are you fasting? Do you have weight loss? And the patient is suffering from malignancy. If answer to all these are yes, most likely the patient have severe or moderate malnutrition. These are the situations where you busy clinics, you don't have time to do anything. So once you diagnose the nutrition, its severity and malnutrition, what will you do next? That is the typical question. So as a doctors or dietitian, we doctors should not tell that, okay, I will just call my dietitian, rest is her job. No, it is not like that. We should also have some understanding about what we should do after diagnosing a disease called malnutrition. So we use a term called medical nutrition therapy. What medical nutrition therapy essentially means that just like any other disease, we assess the patient, diagnose, and we prescribe and monitor our prescription. So this is actually another form of medical therapy with the prescription. So why do we need medical nutrition therapy? This is basically to maintain the protein balance. Irrespective of any disease the patient suffers, if the protein balance is not maintained, the carbohydrate, protein, or any enzyme or any messenger balance will be disturbed. So if you ask me what is life, life is basically protein. Calories are there to run the system, and the fat is just like a fuel in an engine. But if there are no proteins, no life. Okay? So these proteins also maintain the motor, cognitive, and immune functions also. The immunity is basically highly related to protein. And if you want a very enhanced recovery for disease and operation, we need to maintain the protein balance. If the protein balance is not maintained, we will suffer from protein energy malnutrition as well. So there are several methods for medical nutrition therapy, starting from food, enteral, parenteral, tube, nasogeal, nasogastric, whatever form is applicable, please use it. Multiplication of usage is also possible, but under usage is not recommended and it has to be discouraged. As a general rule, if the gut works, use it. I already told why we should use the gut, because gut itself maintains a system balance, gut-brain axis, and it also supports the integrity of the gut. If the food is not given to the intestine, intestinal failure will happen. Exhaust all oral routes first and then start on non-oral enteral route like nasojejunal feeds, which I already mentioned. Why enteral route is preferred? Because by evolution, Homo sapiens are the GI system is made like that. Okay. Second is a low cost and easy to administer and thus less metabolic complication. Our intestine is a very good filter to avoid toxicity. If you administer so many things parenterally, the patient can land up in toxicity, but whereas the same unprepared contents, if you administer orally, patient may not land up in toxicity because of the excellent filter capacity. That results in no risk of overload. And generally, as you know, we have a lot of from the cephalic reflux onwards, many of the human refluxes are tuned for eating. So it gives a very good well-being for the patient. His morale will be boosted. And it also decreases the likelihood of bacterial translocation. As you know that gut biome is a very big thing in the disease generation. It preserves the immunological, the nutrition preserves the immunological functions of the gut. So consciously, we should put every effort to feed the gut, even if it is in very less quantity. So when you give enteral nutrition, so we will be thinking the patient is taking or it's a normal diet. For switching from normal diet is required in malnourished patient, normally nourished patient unable to eat. You don't predict a good eating in next 7 days. And sometimes, you know, the small bowel is in the adaptive phase. then there may be increased needs. The calorie requirement, all calorie requirements are calculated 24 hours basis, and the calorie requirements are not met. Those situations you have to resort to enteral nutrition. When to avoid enteral nutrition, the dictum is, unless you are really convinced about the necessity to avoid an enteral route. Enteral means basically the jejunum and ileum. Then only avoid enteral route. Every day you avoid enteral route, it has metabolic complication, nutritional complication, infectious complications, and immunological complications. So you are increasing the infectious risk and immunological risk to a patient by avoiding enteral nutrition on a daily basis. When oral feed is inadequate to meet body requirements, sometimes there may be a situation that like burns and trauma, what happens, the requirements are very high. Even a normal patient may not be able to, very well preserved patient may not be able to adapt the oral nutrition. So we may have to give supplemental nutrition. Transpiler feeding is otherwise called a jejunal feed, or you call it any other name. So long tube introduced to the mouth through the stomach, duodenum, and to the jejunum. This is a very excellent route for nutritional support. Why it is excellent route? Because you are directly introducing the feed to the digesting and absorbing organ, which is the jejunum and ileum. Okay, and you can really measure it. The stomach, which acts like a bag and capacitant organ, will not interfere with the delivery of this route. So this is a very excellent tool, but it has a risk of necrosis in nose or cartilage, and there is a small risk of aspiration as well. So when you adopt a transpiler feeding, there is when there is severe gastroesophageal reflux, gastroparesis. Gastroparesis is a accompaniment of many critically ill patients. We underestimate this issue very often, especially ventilated and sedated patients. So what happens, we keep on measuring the gastric residual volume. We keep on giving, stomach acts like a bag. It stores, we will not have any assessment how much is transgressed to the jejunum. So it is better to have a transpiler feeding, which is definite. Probably jejunostomy, especially in surgical patients, we know post-gastrectomies, post-intestinal resections, many major surgeries like pancreatectomy, many people adopt a jejunostomy feed. Why jejunostomy feed is adopted? Because while you are doing surgery for other indication, it is easy to make a jejunostomy. It is one of the most definite feed, and it gives you access to the small bowel. Many of the surgeries, small bowel loops are used. So the most blind spots on the abdomen is the small bowel. Once tube is there, it will also give you ideas about feeding and bleeding. So this is one of the very good tool for feeding. So how to, this is a very complex names which I put here, but ultimately you have a set of products in the market. But what we have to learn in the baseline is whatever possible, let us give it. That should be the word in nutrition. Okay. Don't try to too much micromanage the nutrition. It will not help, because there is a complex environment working with the disease and nutrition in the body. So whatever possible, you give it. Let us say you are an onconutrient product. Okay. Now the onconutrition product, let us say we think that it is not useful in chronic liver disease. It is not so. In one of the randomized trials in nutrition, we are used one of the onconutrition products for the patients with waiting for liver transplant. So unless we are very clear contraindication with respect to the contents of the feed, whatever available in your country, whatever license, you can use it. So there are several modes of food delivery, like bolus, intermittent, cyclic, continuous, whatever it is. You name it, it is there. But some of the bedside tips which I wanted to share here is, please remember that all the tubes and feeding are associated with aspiration risk. So most of the patients aspirate in the midnight, or let us say 12 p.m. to 3 to 4 a.m. is the peak time for aspiration. So if you are doubt, you can stop the feed at that time. Don't take any chance. If you have a less staff in the ICU, especially in night hours, you consider that fact before deciding whether you to give bolus, intermittent, cyclic, or continuous. There are other problems like patient is getting shifted for investigation. That time your feeding might be stopped. You might want a continuous infusion, but what happens? Some 5 hours the patient is CT scan room, it got disturbed. So then you may have to resort to intermittent feed. So every 24 hours, this method of food delivery also will change. Most of your enteral formulas, just for quick remember, 1 kilocalorie per ml is the calculation. So we may get patients with the fistula, stoma and all that. These patients will have a nutrient loss. You might be prescribing good quantity, but at the same time, we might be calculating the loss only in terms of fluid, which is really wrong. This fluid, what you see in stoma bags, contain the unabsorbed nutrients as well. So if you don't replace in extra quantity, the patient is going to suffer with severe malnutrition. So when we will give parenteral nutrition, as I told, when enteral route doesn't work, when enteral delivery is insufficient also. So you have 3 areas: normal diet, enteral feed, and parenteral feed. When enteral delivery is insufficient also, please support with PN. As I told, route has only secondary importance. And proposed nutrition plan cannot be executed by enteral route alone. Normally, we calculate on 24-hour basis. And if your calculation is not meeting the required need, please support the patient with the parenteral nutrition. So basically, we have glucose, lipid as macronutrients and micronutrients and vitamins and trace elements. So approximately, I'll just apprise you how we calculate the TPN requirement. It's all about the requirement for the energy. That is the basic calculation. Let us calculate the energy first. Let us say it is 30 kilocalorie per day. Then you split up into carbohydrate, lipid, and protein by assessing their capacity to generate the energy. For example, fat as a 9 gram, like that. Protein and lipid protein and carbohydrate as 4. So you reverse calculate based upon the carbohydrate need. Along with that, we have to put the fluid order as well as electrolyte orders also. If you don't concentrate on fluid and electrolyte prescription, what really is going to happen? There will be a lot of problems, metabolic problems in the body, and intestine may not move, systems may not function, and absorption will be compromised. So this is the approximate calculation in surgical patients. Generally, we calculate 25 to 30 kilocalorie per kg per day. But if you have more stress, more injury, and significant stress due to the surgery, you may have to give excess. Very high excess is required in burns where there is no skin, and there is a lot of loss of fluid, serum excretion, and protein. So those situations, you have to give excess. Please be sure that you are assessing the kidney function also while you are giving very high protein intake. So generally we put a 5% glucose solution, but sometimes please do not hesitate to give higher concentration of glucose. Why it is? Because sometimes glucose may be the only energy source you may be able to give in a particular patient, especially in emergencies and acute situations. That time, you are already having a patient with a severe malnutrition, you can use higher concentrations of glucose. So the essential fatty acids is very essential for the integrity of the cell, its membrane, its consistency, and almost everything. As I told, it gives the oil. And one of the problems is, please try to understand that the energy requirement from the oil should not exceed around 30%. At any cost, should not exceed more than 40%. So this fine balance between carbohydrate, protein, and lipid has to be maintained for the smooth functioning of each of them. So fat can be administered to peripheral lines as well. So it is not must that everything has to be, all PN has to be administered to central line. peripheral lines can be used very extensively. We use it very often, especially in patients with a partial oral nutrition. It's a very effective method. On a 24-hour patient, you can also see that one day patient receiving partial peripheral nutrition. Next day, he might not be receiving. Next day, he'll be receiving again. So these combinations are really good in adequate nutritional support. So what we have to remember is what we are trying to prevent is protein catabolism. By giving carbohydrate, by giving fat, we are essentially trying to protect the proteins. If you are not giving adequate carbohydrates and fat, the proteins are going to be broken down, and that will have enormous implications on the patient recovery. Say it is surgery, say it is antibiotic use, say it is movement, say it is cognition, on almost everything. The protein balance is not maintained, patient is going to suffer. The final additives will be vitamins, minerals, and metals. Please, this is the most neglected part of nutrition. The important point is most of these things body stores in good quantity, but in especially chronic disease, severe malnutrition, especially low socioeconomic status groups, these patients will come with already with existing deficiency. So what happens in disease, they will suddenly open up your bank of minerals, metals, and vitamins. It will be suddenly exhausted in a few days, and you will be wondering, I am supplementing, but no effect is coming. These might be going to the already depth storage in the body. So there are several calculations, but these all can be referred by internet or Google. But ultimately, we need some calculation for this micronutrients and water and electrolytes. So why it is important? Because especially in patient with a chronically debilitated patient in the hospital, unless you don't maintain the micronutrient balance from day one, your supplementation of protein, energy, and fat are not going to work in long term. It may work in short term, but in long term, it may not work. And as I mentioned, fluid calculation, please have a tight control over fluid calculations. So in mild to moderate malnutrition, peripheral parenteral, if you want to avoid central line, if you have central line sepsis, jugular vein thrombosis, it is better to have a peripheral parenteral nutrition. If you ask me what is the most important problem we encounter in hospital with nutrition is prescription delivery mismatch. When we go to morning rounds, we always hear that 2000 kilocalories, this much protein, this much fat he has received. So, but you ask him, did you actually ensure that the patient has received it? You prescribed it, fine. You prescribe 1 gram of any antibiotic, the patient will receive 1 gram. But if you prescribe, let us say 1000 kilocalorie to a patient, it is extremely unlikely that in Indian setting, the patient will receive that exact kilocalorie. So this prescription delivery mismatch is one of the major problems in hospitals. And we should keep a watch on it on a 24-hour basis. Why? Because there is some concept called catch-up nutrition. So if you have a prescription delivery mismatch, or let us say 500 kilocalorie today, next 3 days are very important to add this 500 kilocalorie to his next days and next day requirement. So like we calculate fluid negative balance and positive balance, we have something called a negative balance in nutrition also, and you have an additional clinical burden of calculating and administering this negative balance in the next few days. Otherwise, the patient is not going to recover as you expect. So the new concept, what generally we follow for so many years, now it got a new name called Prehabilitation. It's a practice of enhancing patients' functional capacity before operation. So as I mentioned before, the moment you diagnose a disease, till the patient is completely back to his self before the disease, what we call complete rehabilitation, you count the days, how many days it takes. So now enormous amount of literature is coming that you spend a significant amount of time before surgery to prepare the patient, even if it is a malignancy. Let us say we have a pancreatic cancer diagnosed, and we think that we tell the patient that see, you have to be operated in 1 week. Your nutrition condition is not good, but you have to be operated 1 week is probably a scientifically wrong statement now. We have to spend enough time to prepare the patient, then operate, then the post-op recovery will be very good. The expenses will be reasonable and the time for rehabilitation will be very short. So every surgical unit, we have to have people who are consciously putting effort to put their entire thought process on prehabilitation rather than concentrating on what nutrition we have to give post-operative period. That is also important. But at the same time, if you put more effort on prehabilitation, one of the essential components of prehabilitation is nutrition. The patient is going to recover very soon and your rehabilitation will be very fast. And that's all I have to say. And thank you very much for the kind attention. I hope I am on time. Yeah.
Thank you so much, Dr. Biju. That was an excellent presentation touching on everything without going too much into the details so that we could get a holistic vision of what you're at. Over to you, Lekha ma'am, for your comments.
Thank you, sir. An excellent presentation. You have touched on about the nutrition aspect, especially during the pre also, which is very much essential. Most of the time what happens is the pre-nutrition, pre-status is not being looked into. It's only in the post the intervention takes place. We already have few questions from the audience. So I'll just start with that. We have Deepika asking about the cachectic patients, sir. What is your take on introducing early parenteral nutrition, that is pre-operatively? Would you suggest?
Yes. So one important thing about a very cachectic patient, especially in elderly, they will have metabolic consequences. Okay. So there is something called overfeeding symptoms, and so we have to be very careful about overfeeding in these patients, because even if you see what we are giving are basically metabolites, they are going to be metabolized through the bloodstream. So they may not withstand the this metabolic insulin. So go slow. How you will go slow? The safest is give carbohydrate first. Okay. Don't give excess amount of protein in the first 3 days unless the patient is showing some improvement with the carbohydrate. This is the dictum we have to keep in mind. Okay, that's what the advice I wish to give. But if enteral route works, you give it slow, steady, and target the first weekend. Target the first weekend for your zero balance nutrition. You want to calculate what is the next day requirement, but start from the second week in debilitated patient, not in the first week. First week will have complications.
I too agree with what you said, like going with the parenteral ONS, if we can start with initially, if it's working out, going with that would be the first choice. And so the next question she has asked is like about the bolus feed and about the continuous 24 hours feeding, which would be better to have a good glycemic control. This is post-surgery. So would we suggest a bolus feed or a continuous infusion?
Yeah, post-surgery, continuous, so it depends upon vertigo. For example, is it, are you giving to the stomach? Are you giving to the jejunum? Are you giving any other methods of parenteral also? So the important point is gut has a very high adaptive ability. Even if you give, your delivery might be bolus, your delivery might be intermittent, your delivery might be continuous, but that is not the way it gets absorbed. So please remember that very well. That's not the way it gets absorbed. Jejunum and ileum are also organs with a significant capacity. Okay. But what I wanted to emphasize is you prefer the delivery methods based upon the risk of aspiration, based upon your ICU setting or ward setting, and based upon number of staff available. You put the patient on continuous infusion. Now you don't have a nutrient pump. Okay, you are putting in the normal infusion rate. So there may be in the odd hours on the day, somebody will come and connect it to the IV line. This is a very high risk. So these continuous or intermittent or second, I will give some secondary importance to it and more importance of patient safety. So Lekha can also give some inputs regarding this.
It's very true. But one thing about is that if you have a continuous feeding, you go for, you have a gravity bag, and then you are able to adjust. That's what usually we do suggest for the home enteral nutrition. So if they have a gravity bag, it becomes easier. Like the night feed, you give around 11 and you have a gap of like 4 to 6 hours, they can be that. Without that, going for wouldn't be apt thing. So that is one thing, sir. And I would like, Sanjila Mary has asked about chyle leak, sir. What would we do for if the patient has chyle leak? So to go for the nutrition intervention?
Yes. So chyle leak is a vexing problem. Okay, it depends on the type of surgery. For example, if there is a major lymphatic drainage channel injury, it's going to be a problem. And even if the best nutritional support, the patient may need a revision surgery or some form of intervention sometimes. Okay, but the essential component is it results in significant protein loss and the fat loss. That is the problem with the chyle leak. So you can always give more importance to protein and fat supplementation in chyle leak, but remember that major leaks difficult to handle. It's very extremely difficult to handle.
Sir, I would just like to add on, how about giving a totally MCT based product in such scenario? Like we do have products which are like ONS, which are almost like MCT based, 90% MCTs or 70-80% MCT. So going for such options during that time?
Yes, it will help healing, but at the same time, please remember that this patient is operated for some specific disease also. So he has to recover that. His adjuvant therapies and other things are scheduled on a particular date. Okay. So by simply chasing on the chyle leak, just by nutrition sometimes may fail. That's what I wanted to say. Let us say we have thoracic duct injury and you have a scheduled, you already patient already received neoadjuvant therapy before, surgery done. Now he's waiting for a post-op therapy. Sometimes it's better to intervene rather than continue on nutrition for weeks or sometimes months.
Would you suggest parental nutrition at that time, sir, like for a chyle leak?
Yes.
Parental would be a better option at that time?
Yes.
Okay,
Yes,
thank you, sir. So we have a next question about like, you know, when we have colostomy or ileostomy drain, what would be the best route of nutrient delivery?
Ileostomy?
Ileostomy and colostomy. When the
Oral
patient
only.
is not
Always oral only. But the point is, it depends upon where you made the stoma. Okay. Sometimes some situations, especially in gangrene and all that, you may make a stoma as well as a distal mucus fistula, what we call. So distal to that, there is significant amount of small bowel. So refeeding is a very good option. For example, it can be very wide. We practice refeeding very widely. Okay, so you may have tubes coming with the bile, pancreatic juice, intestinal contents. Only thing is you have to filter it if possible and try to give it, which will have more adaptive ability to the distal bowel. So always use a distal bowel unless it is very close to colon.
Sir, I would just like to add on with the talk what you said, the topic about that prescription mismatch. That is what we usually see in most of the centers, and then what we aim, we are not able to meet. So this is just an input from my side. What we do in our center is we have made it a point to enter the supplementation in the drug chart itself. We started following this, so that error has come reduced now. Otherwise, what happened? The dietitian prescribes, but that is not being carried out. But now when it is in the drug chart and mandatory, the note is there from the doctor's side. So it becomes a mandatory that it is being given. So that non-delivery, the catch-up is easier in that way. So I just thought I'll just share my idea about
that's a very important point. Probably the most successful models in nutrient delivery is handing over this delivery responsibility to nurses. Once it lands in their shoulders, mostly the prescription delivery mismatch will be very less.
Very true, sir. Otherwise, like you plan everything, do the intervention, but finally it doesn't work out. That is something which is very difficult. And sir, like one more query I would like to ask you is that about the prehabilitation period. what you said, like the prehabilitation period when we have, how long can we wait, sir, for the nutritional intervention to do and like to have a good nutritional status? How long a period would you say is safe? Like you do an intervention and we can wait for solid 2 weeks and all, is it okay?
Yeah, so what we normally in early 2000 and let us say 2011 to 13 period, you know what happens in public sector hospital, especially like us, we admit the patients inside the ward and we used to wait for long 2 to 3 weeks. This is an incidental and very eye-opening finding we got, that we always keep them on some nutrition supplementation. Am I audible?
Yes, sir. Now, yes.
Yeah. Okay. Yeah. So we kept on some nutritional supplements. So what really happened? Their recovery got improved. Is there any interruption? Or?
Slight interruption are there, sir. You're breaking in between.
Okay. Now is it okay?
Yes, sir.
Okay. So this is a we never intended to do like that, but we got a collateral information like this. So now we started using that methodology for the last 5 years very extensively. So what we do is, the moment the patient lands up in OPD, we don't operate them next week or next day. Okay. We give them spirometry, we give them nutrition, several packets, injections, and make them fit and walk. The 3 minutes walk or 6 minute walk or 10-step climbing, whatever it is, then you operate. Okay. But ultimately, it is beneficial. So 2 to 3 weeks is what we generally aim, unless the patient is having severe jaundice and otherwise. I suggest 2 to 3 weeks.
Okay, sir. Thank you, sir. So these are the questions from the audience. Any other further questions to be asked by delegates? You can post it in the chat box.
So, Dr. Biju, you have mostly talked about long-term problems and patients with major nutritional deficiency, and I will take home that point you mentioned, that you have to consider almost anyone malnourished unless otherwise. So as an anesthetist, one of the things I'm more interested in is in the shorter version of the problem, that is immediate perioperative period, and not necessarily for only for major gut surgeries. So what role do you think reduced fasting times both in the pre-op and post-op period, what effect do they have on recovery of patients?
Fasting, madam, you're asking about fasting time?
Yeah, reduced fasting times both preoperatively and postoperatively. How much relevance do you think it has for?
So, in a conceptual or philosophical point of view, what we have to create a scenario that a nutritional support is given pre-op and it is continued on post-op with a small and very small as surgery. That is our aim, whatever it is. So the mindset we have to change, that surgery is a very major event, but you just exactly put it the reverse way. The patient is on a pre-planned preoperative nutritional support, which is going to continue in the post-op, and during surgery, give a small interruption for that. So if you keep that as a philosophical principle in mind, you will be very hesitant to keep the patient NPO more than 6 hours in the pre-op. That's also in night, there's no big problem. And most of the major surgeries, you will be able to start the nutrition on next day or next to next day, even if it's a pancreatectomy. So we try to reduce interruption to less than 48 hours. That's what I recommend. If it is less than 48 hours, mostly the metabolic consequence, all that will come down to a great extent, and your continuum of nutritional care will be intact. That's what I wanted to comment on that.
And then the other topic which is often discussed is about carbohydrate preloading. So what are your views on that?
I agree, but if you have a good prehabilitation nutritional plan, we have not tried it very significantly, but many intensivists and surgeons like Dr. P.C. Vijaykumar, they try it very often. And people say they are excellent results, but we are not tried it yet.
Perhaps it's more common in the non-governmental or corporate sector because we don't usually wait. Like Radhakrishna, I don't think we'll wait 3 weeks to operate on a patient. So, what's your view on that, Ilango? Transplants are probably planned, but obviously not disease donor. But for other surgeries, what's your take on this waiting period of 2 to 3 weeks?
Yeah, we just cannot do that in private hospitals. The one luck we have that compared to public hospitals is that the incidence or prevalence of malnutrition in our patients is quite on the lower side. I won't say it's completely not there. And relatively, we are seeing more and more obese people rather than malnourished, which is, of course, a type of malnutrition. And that is our challenge in our place. So we have not had the opportunity to intervene like that. But with regard to transplantation, we have always had difficulties, not in live donor transplantation. We have a good nutritive support in the perioperative phase of a live donor transplantation, exactly like how Dr. Biju shared. The one thing which we constantly add is probiotics. But for disease donor transplantation, especially when they are under the care of a non-transplant hepatologist, we find them extremely malnourished, and it has a serious impact on the outcome. However good your surgery is, we have seen that the post-operative phase is extremely prolonged, and it is difficult to get them back to their normalcy. The immunosuppression is always haywire, and infection risk is always there, even at 3 months. So we are very, very scared to operate on patients who have not been under our care, who walk in for a disease donor liver transplantation. But the other situation surgeries, I think we are quite okay. We actually struggle with obesity in most places in the private. I think Patta sir?
Yeah, actually, to answer Vidya's query as to whether we have patients who require or whom we follow preoperative nutritional improvement, by and large, a lot of our elective patients do not require. And the ones who require are the ones who come with obstructive jaundice with cholangitis, or where we reduce the bilirubin and infection and then have some time. Those groups. And an occasional patient with corrosive injuries to the upper GI tract, will we have time, they have a jejunostomy tube for feed and build up, because when these people come, they're malnourished, because majority of the patients who come to the corporate sector are quite well nourished, and they come early in case they have a malignancy. So the numbers are not so many. The numbers are few. An occasional esophageal malignancies fit into this criteria. But having said that, we do have patients who the typical tertiary care, abdominal infection, post-surgery elsewhere, or those sort of patients where we sometimes we may get time to work on the nutrition before we go in for a re-exploration and stuff like that. Regarding the short fasting and carbohydrate overload, we did try. We did try sizable numbers. Vidya, Suren was doing a study, although we didn't really tabulate and find out how useful it is. But we did try, as you rightly said, the corporate sector can try all this oral carbohydrate overloading, but that seemed to work. And we do have a special interest in ERAS, and as you know, so we did really try that. But having said all that, I think this understanding nutrition for surgeons has become very important, and Biju's been doing a great service in that area and is taking it up seriously. And I think if not as important as infection in surgery, I mean, it's equally important, I feel, nutrition, and it should be introduced at a very undergraduate level, and people should know all the terminology, and even during exams, theory or viva, nutrition has to be introduced also. And the other thing is about, the dietetics and nutritionists come a very big way, and dietitians are taken a very serious interest in surgical nutrition. Having said that, I feel that there should be a constant communication between the surgeons, the dietitians, and the nurses. There seem to be a lot of gap between these three, and that's when all the prescription mismatch comes. And really, actually, there should be leadership in that area. Somebody should take leadership, and we should work together and make it much more meaningful, because these days, of course, in our unit also, every post-operative patient, there'll be a presentation on what was the nutrition, what was the percentage calorie intake required, and how much, we have a tabulation and somebody working on that. But having said that, a constant dialogue between the clinician and the dietitian on a daily basis should be there. Quite often, dietitians might not understand what surgery was done, the junior ones especially, and what is the physiology, what does the drains mean for, I think there should be a constant education, just interaction. The nursing should be just like infection nurses. I think there should be dietary specialized nurse. I don't know whether Biju have that group of people, and whether like also has any dietitian or the nursing interested in dietetics, to understand as much as a dietitian or a clinician does. I think there's lots need to be done, but it's very good that we have a lot better understanding about surgical nutrition now than what was 10 years ago. And there's so many products are available. Just like antibiotics, so many, and frankly, many are not aware of what they are and how to use them, and so on. Especially, I think at internship level, all these things had been introduced. Good that Biju is doing a lot of good work in that, and I'm sure in days to come, many surgeons will be more, adept at surgical nutrition.
Dr. Punitdar is logged in with us, and you have the unique experience of recently having worked both in the private and the public sector. So did you find nutrition challenging more in the private, or it's the same?
No, it's interesting that you say, can you hear me?
Yes.
So it's interesting you say this, because I actually agree both with Pata and Biju, because when I did the change, like Pata said, in the corporate sector, the kind of patients which come don't really need that. They're well nourished, even with advanced cancers, and that's a change I saw even as I moved to Cochin, that in Delhi, in the government hospital, we used to have almost 90% of G junction tumors inoperable. Whereas in Kerala, the corporate sector, they were 90% were operable. Also, the general nutrition in Kerala is higher. So I think it's there are just a couple of things that, there are two counterbalancing sort of conundrums here, because Pata said that we shouldn't delay, and Biju was insisting that we have prehabilitation. Actually, I do agree with the prehabilitation delay, because I think it's got two or three at least clear benefits. One is nutritional. When I moved to the government sector, I realized that we have to delay the patients because of inadequacy of dates for surgery. So two clear benefits came. The patients who are malnourished or borderline nourishment, like Biju said, we should consider all malnourished until proven otherwise. So they're all borderline, and the hospital actually renders them more malnourished. And these patients, if we can show in that 2-3 week delay, if we are able to show a rising albumin or a improving nutrition, they definitely do better than those who do not, sort of build up in that time. So there's a very clear benefit. The second advantage is many of these are malignancies who have this, borderline malnutrition problems. it gives them time to emotionally and mentally adjust. You know, I've been in the kind of setup where we've been taught by everybody, all our seniors, that it's a malignancy, you have to operate on it day before yesterday. I think there's nothing further than the truth. Anything which is going to, spread in those 3 weeks, as surgeons, we are not going to change the natural history of that particular disease. That's very, very clear. So if it's say a pancreas, say a gallbladder, something with a very short tumor doubling time, yes, we should go ahead with surgery as soon as possible. But somebody who's clearly malnourished is going to do badly. That's absolutely clear. But this 3-week time also gives them time to mentally adjust to that tumor, to that diagnosis, rather than being told suddenly on the 3rd day of surgery and they react to it badly. So I think both the nutrition and the emotional things do help in that rehabilitation. Now that's counterbalanced by the better nutrition in the private health, but I think we should take that message there clearly. The second is about feeding jejunoscopy. I don't think it's adequately discussed in the Western literature as much. In fact, there's enough literature against it in the post-op setting with all the complications they list out. So I see a trend towards people dropping FJ. I think in a resource-constrained setting like India, feeding jejunostomy is an extremely valuable tool. It can save patients. It saves tremendous amounts of money as compared to parenteral. We can actually decompress an ileus and have it faster. Even if a little bit of nutrition can be given, it reduces the septic complications. Whole host of benefits are there of using a feeding jejunostomy. So contrary to the current Western literature, I think we should use it at least as frequently as we did, say, 20 years back. So those are sort of messages I wanted to pass on.
Does anyone else have any questions, or Lekha ma'am, do you have anything to add?
Thank you, ma'am. So it was a wonderful section. I think, when we go on with the nutrition, from the dietitian's perspective, it keeps changing. One of what I like here is, as you said earlier, when you're having the ward rounds, if the dietitian, the nurse, how we follow is, we have everyone as a team. The care team rounds are done together in the ICU. So there ends, the problems are solved much better. The understanding is there when we are there together. So a care team rounds together, that is the doctor, dietitians, the nurse, everyone together will help us to understand each other. So when there is a requirement also, when that has been said to the dietitian, they'll be able to follow it better, especially when it is a junior dietitian. They don't understand what exactly has to be done. So the hand holding truly will help them also to ensure that the right requirements are met for the patients. So I thank Dr. Biju sir for such an enlightening section. And it's I truly agree that intervening with the power to nutrition prior to and right after a surgical procedure would make a world of difference in the patients. So we need to follow that, and a tactful and an evidence-based approach is what is needed. That surely will strengthen. Thank you all. Thank you. Over to you, Vidya ma'am.
Thank you, Dr. Biju, for sparing the time. And already Ilango has pre-picked you by calling it a primer, which means there will be more to follow. So perhaps every 4 to 6 weeks, we'll have something on nutrition, maybe for specific case scenarios or whatever is likely to help the trainee surgeons and other people who are logged in. So Ilango, what do we have on next week? You're muted, Ilango.
Oh, I'm sorry. So we have some interesting sessions coming in the next few weeks on NLS. I think the first few things are how to build teams. So it's a generic topic. Surgeons are people who work in teams. So we have Mr. Suresh Kumar from L&T IDPL, who is one of the chiefs of that program. So he is going to talk on how to build teams in a generic topic. And we have Dr. Karthik Damodaran, who is an interventional radiologist, to teach about procedural learning and expertise development. What do we learn from across specialties and how to develop skills? So that will follow. We have planned one more session on fluid management for surgeons, drop by drop, and those will be the sessions for April. So do join us. We want these to be very good learning sessions for young surgeons, as well as for slightly older ones like me. I think every bit adds to our skills and help us deliver better patient care. Thank you everyone for being here, especially to Biju Poattakat and Mrs. Lekha. Thank you very much. Thank you.
Manu, you have put your hand up. Do you want to say something, Dr. Manu? Okay, I think he put his hand up by mistake. Is that on the coming Thursday? The topic is something related to surgeons as well. So, but it's going to be immunotherapy. What's the latest on immunotherapy in cancer? So we hope that many of you will log in on Thursday for Marvelous Medicine as well. And we'll meet again next week, Tuesday, with another episode of Let's Learn Surgery. Thank you for joining. Good night.